And again, that was a lot to do with a lot of first sequencing the first module out of the gate, those kind of things. I've taught in psychopharmacology that weren't first, and I've never had, one third fail before, but they rallied and we corrected the problems, but we should be free sooner, I guess, pretty much. So on the quiz, does everyone remember Friday when I said those notes aren't showing up on the quiz? I think it was on Friday. Do you remember this? Anybody remember this? I'm like, oh, you're supposed to capitalize the first word, and try to eliminate grade errors in the system. That's because it pulled up and extracted an exam before the final updates. So I have no idea how we did that or why I did that. But basically what I'm doing for that first quiz is if you did it, and I know you did it, it should be most everybody, then you just get the points for participation. It's still a quiz grade, but it's more like participation and try to fill out. It's just really out. I can't have two different quizzes and grade you on the same thing. And then maybe give us more details on Thursday. Not many. Technically, the questions, the spirit of the questions are still there, but basically it just becomes a default. If you did it, it should be everybody unless, you weren't, unless you skip, in which case, you're losing these points. Otherwise, it becomes a participation quiz, and it's kind of like points automatically. That said, anybody feel like they did horrible on that? Anybody feel like they did great on that? Who felt like they nailed it anyways and they would have got all the points? You guys just being quiet or just really like people? Who thought they did decent? Who thought they could have improved? There's the scoop on that. Yes?
With regards to what drug was taking, what was the answer to that?
The answer to that was disulfiram. And the clue in the case that should have led you to disulfiram are the other two medications both cause at a relatively common rate insomnia. Insomnia is the primary reason that you complained of the term period.
I'm sorry, is it grade posted? No.
The grade is not posted.
Okay.
The grades are not synonymous for Thursday and Friday. Because the wording extract, I don't know, it's a new system, so I'm still trying to figure out the system, but extract whatever, because there's two modules now, right? There's two separate modules, so I don't know where Thursday, Friday, where that extracted in the older exam, why it didn't find the most recent one, so I'm trying to figure out why it did that. So I didn't post them because they're apples and oranges. They should be approximately the same because I didn't really have that much beyond it. Fine-tuning stuff. Usually the final revision of questions are those specifics that make the question less than clear. So, just to be fair, I just.
Hi, just before you start today, I wanted to make a quick comment. I've had several people from this class ask if they really needed a Puro book, and I've taken this class before, so I just wanted to make sure everyone knows that it's a really good resource, and you definitely need the book and to go over the chapters. The tables and stuff are really good.
You hear that? Anything else? Yeah.
So is that due before you stop teaching
No, it's due while I'm still here. Yeah. I mean, I'm still going to be around as a coordinator. I'm not going to be talking about therapeutics and Wednesdays come, early March. Infectious diseases one time. So no, I prefer that it's while I'm here. I'm thinking about therapeutics while I'm doing grades. Because at the end of Psychopharm, it's a little different this year because I leave the country so abruptly. That didn't take so good. I'm sure last year I had all 7 weeks of Psychopharm. So I waited until later on because I wanted to clean everything up and get rid of poorly written questions and have extra credit. This year it's a little bit different. You're going to have 2 different people, so it's not that but yeah, probably won't, once it starts getting infectious disease. There's no deadline.
basically
Yes. because I'll be cleaning up my stuff for a couple of times. Yep. The exam, electronic. This week. Anybody else? Yeah, no, it feels weird for me to teach them in class to leave, it's kind of odd for me. But you guys are teaching an exam on Monday, but Devin is also psychopharm, and she's going to proctor the exam on Monday with the other professors. But she's not going to be able to give final answers on what I want and don't want like that. So you're going to, she'll be around. Well, of course, she's going to be teaching you guys. You guys are going to move on. So it's a little bit weird this year, but that's the way it is now. Travel to work. And, have to travel to work. That's the way it is. Yeah. Well, I mean, I can tell you from experience that you're going to want to wait for me to clean stuff up. Last year, I don't know if Crystal remembers, the grades were incidentally produced before I cleaned the grades up. I was literally in my office in the dorm grade, and I could hear people in the hallway, like, do you remember this, Crystal? It was like a panic. Like, there were people studying in the conference room, and I could hear everyone screaming, oh my God, this, that, and the other. But it wasn't the final grade. I hadn't even cleaned anything up yet. So, trust me, you're going to want this. Huh? It happens. Not normal. Doesn't everybody? No? No, I'm not a techie guy. The electronic exams are just so much better in terms of, you do a hard copy, the whole grading process and getting rid of 4 questions is much harder, it takes a lot longer. With electronic format, you can do a lot more with grading and curving, and getting rid of 4 questions, and this question was good, this question wasn't. But there are drawbacks too, like respondents. So I wouldn't say I require it, it's just, that's how most of it, that's how I was taught to do it. So I don't know if you guys thought the substance use part of this, in terms of the content, in terms of the content matter was easy or difficult or where the gauge is, but I definitely know that now that we step into depression, that it gets a little heavier because we know a lot more about depression. It wasn't even until my lifetime that addiction was even considered a brain disorder. Depression, and all psychiatric illnesses were one of the last, disorder group to be considered true medical illness or true diseases. Where it really started to turn the corner was with OCD. OCD was the first psychiatric disorder that they said, well, you could call it a neuroatypical disorder. Now you could probably call a lot of these neuroatypical disorders because you can actually image parts of the brain that are dysfunctional. But depression was ahead of the curve. So OCD was the first disorder that you could actually document changes in the brain before and after treatment. Addiction was probably the last, one of the last. So we don't know as much about substance use as we do about depression. Plus, depression is a major problem in modern day, so we know a ton about it. So it does get a little heavier because we know more. There are a lot of medications that you have to know. We know a lot more about the pathophysiology. So, I don't know what your baseline is in substance use, but it is going to get a little heavier. You've seen this slide before. Today we're talking about depressive disorders, and specifically I'm talking about major depressive disorder. There is a whole group, a whole cluster of depressive syndromes. In an hour and 15 minutes, today and tomorrow, 2 hours, 2.5 hours, fairly enough time to go through depression. Probably not even enough time to go through depression. And now on top of that, depressive disorders that might be. Because I'm sure we'll probably talk about better talk about that. That's for sure. She had better. If she doesn't, let me know. MDD, major depressive disorder. Here's the spectrum that I was referring to. There's a whole list of these. You've probably seen some of these if you watch TV, you see commercials for them. If you work in pharmacy, you definitely see medications. You cannot, think about this particular class of medications, you can't work in any setting without seeing them. Guaranteed. I don't care what setting you work in, you're going to see antidepressants, right? Anybody surprised by that? No, right? I mean, it's a depressed society, I guess, but we're going to look at what we want to do. The national rate of depression lifetime, and again, there are different studies, but the National Comorbidity Survey replication study is one of the gold standards. There's a handful of them that use slightly different methodology. Approximately, we're approaching 1 in 5 of Americans will experience depression in their lifetime. Approximately 1 in 5, right? 20% of 1 in 5. And the reason I say it that way is because other studies show 17%, but you're basically showing a pretty high percentage for psychiatric disorder, right? And that's a very high prevalence rate for any disease, right? 20%, approaching 20%. Does that, anyone realize the magnitude of how many people that is? That's 20 of you. 20 of you in this room will be depressed clinically, relevantly. I don't know if that's a word, relevant. To a relevant manner, to a relevant degree, 20 of you will be depressed. If you are representative of the U.S. population. And I know this is a very diverse group, it's not exactly representative. Assume you were representative of the U.S. population. The risk is approximately double in women. Double. And this goes across all studies. Most of the disorders I talk about, women are more vulnerable for depression, anxiety disorders, things like that. One of the glaring exceptions we just talked about, substance use disorder. Substance use disorder is an overwhelmingly males, young white males in particular, young males are really the highest risk group. Here you're talking about women, and again you're talking about the younger age. So women in this class who are between 18 and 29 have the highest chance of being depressed as compared to any other population. So it's something you want to look out for. I know it's not good news for the women that are 18 to 29, but you have to be aware of who's at risk so that you can actually try to do things, right? Yeah, you can break it down, as far as you want to go. I would recommend, if you're interested in full epidemiology, because I don't really go too much into epidemiology other than I want you to know more of this. If you want to start piecing it apart on that, you can actually locate and find the literature for national comorbidity. They've got an endless amount of this. I'm breaking it down. What I want you guys to know is the one thing that does not change across sites is the gender. But I would recommend, you can always pull up any of these articles yourselves and refer. We just don't have time to cover them at fast. All right, you should check it out. And if you do, and you find something interesting, let us know. All right. This slide, the take-home point of this slide is there is clearly a genetic risk for depression. Clearly. And maybe that's something you already would have intuitively guessed, but this is just to say, a way to say that no matter how you look at it, you're going to find a genetic linkage for carrying on depression, which basically says, yes, this is a neurologic, biologic, metabolic. There's even evidence now that it's inflammatory disease in the kidney. We know more and more and more and more. And the more and more that we know is depression is clearly a physical disease of some kind that we can now start to tease apart. Okay? And I'm not going to expect you to know specific numbers, but I do expect you to know that there is a large chunk of variance, which basically means if you look at all, you dump in everything, virus, genetics, age, and gender, you dump all this stuff into a big statistical pile that, over a third of the variance. So over, you can kind of think of this is oversimplistic, but a third, or let me say it from the other side, genetics explain approximately a third. This is a large chunk. That still leaves 2/3 unexplained. Is it more invited? So that means, hypothetically, just for the sake of argument, say that the remainder was environmental. That's not the case. It's divided up. Say it was all environmental. What that would be like saying is, well, you can do something for a third of the disorder by isolating genes and trying to figure out how to manipulate those genes, but you still have 2/3 of the problem is something other like environment that you have to address. Kind of an oversimplistic way of saying it, right? But what you need to know is that it is a genetic disorder, it is transmittable, it does run in families, and there's a large piece of the disorder that can be explained by genetics.
So are we saying like in family they have six, they have 4 kids, and the father or mother or something is 22 years of age. So I imagine like the kids get right?
No. So what it's saying is, first off, when you do family studies, you go up, for example, to that first degree level. What that's saying in your analogy, because these are all slightly different ways of looking. If you look at the second bullet, the first degree relatives, that's like saying, if you have depression in your family, and you don't, and you have 4 kids, and you have 4 kids, your kids are up to 3 times more likely to experience depression as this kid will. Right? In a given person, it's saying that 37% of their chance of being depressed, 37%. Again, this is overly simplistic because it's a big statistical mess. It's saying that 37% of your risk, a third of your risk can be explained by your parents' history. But now we have another 2/3 to deal with, like, what's your social history? What is your peer group? What is your environment? What is your psychosocial? Do you have a trauma when you were a kid? It gets really complicated. But that's a big number, 40%. Right? Now, this is where it gets really interesting. I think it gets more interesting. So the next 2 slides, I highly recommend you know them well because they cover, if you know these 2 slides very well, then you can pretty much this is a serotonin slide and this is a dopamine/norepinephrine slide. They're virtually identical, but not. Right? So if you know these 2 slides, you can piece apart the mechanisms of action for most of the antidepressants you talk about. If not all of them. Most, if not all, right? This should be a basic pharmacology. You guys should have already seen this probably, maybe in Selvage or Karen House Connect. But this should be a review. Does anybody want me to highlight important points, or is it completely redundant? Yeah. Highlight. So some of the highlights, all right? Oh boy. So. So, couple highlights. You have, this is the terminal end of the neuron, and on the surface you have transporters. In this case, this is a norepinephrine transporter. You have transporters that after transmitters are released into the synapse, recycle a lot, right? Your body recycles a lot of stuff, which is a good thing, right? Else you have to just keep eating all the time to replace it with new use. So there are reuptake pumps on the surface of the synapse that bring that transmitter back in to the end of the neuron to be used again. Well, right here, then, I'm trying to look at it backwards. Then here you have the VMAT, which is the vesicular monoamine transporter, which takes it one step further, and that can actually, that's where you store these neurotransmitters for eventual release, right? So there are 2 main transmitters that we're going to be talking about. The vesicular monoamine transporter And the surface transporter, which is going to be different for dopamine, serotonin, and norepinephrine. Okay? The vesicular monoamine transporter is going to be able to handle all of these different transmitters. You know, at least for the purposes of this class, you can think about one vesicular monoamine transporter. But when it comes to the surface transport systems, you have to think about them individually. All right? So individual for the surface, and you can think about one broad class for the vesicular. Now, so I'm not going to go too basic because you can review a lot of this. But basically, you release neurotransmitter into the synapse so that it can do something, right? You release dopamine into the synapse so that it can act on the next neuron and communicate and do something, right? This should all be reviewed. Well, in all of these cases, you have the dopamine transporter that brings it back into the presynaptic neuron for recycling through storage or breakdown. Because the other thing that can happen is you don't restore everything, right? Some of it you have to actually break down. So MAO, monoamine oxidase, is a way that you would actually break down the transmitter if you're not going to recycle. You can't store, you can't just keep storing and recycling, right? And you can restore some of it, recycle some of it gets broken down. So two different paths, right? So there's another highlight on the neurons that I want you to know. I'm going to touch real quick on the autoreceptors. Autoreceptors, again, presynaptically, are going to be kind of like brakes. So it's a way, kind of like a feedback, a negative feedback mechanism where if you actually hit the presynaptic receptors for that individual neurotransmitter, that you will slow down self-firing, right? So it's like a brake. Now, you think postsynaptically, the receptors are going to carry the message on. Those are the two big subtypes that we talk about, right? Presynaptic acts like a brake. Postsynaptic acts like it carries the message on. Okay? And you have to keep in mind, again, in some cases you have individual receptors like a dopamine, serotonin, or a norepinephrine. In some cases you have something that can handle both, vesicular monoamine transporter. The other one that can handle both are these alpha-2 autoreceptors. There's the, have you heard of the term heteroreceptor? Who's heard of the term heteroreceptor? You know what that means? Some of you guys that raised your hand?
It binds different receptors, have different, different things that bind onto it.
So one of the heteroreceptors that we talk about here that you should be concerned with, serotonin and norepinephrine combine to presynaptic head lobes. So there are some receptors, again, that can actually work for multiple neurotransmitters. In some cases, they're very specific. As we talk about the medications, hopefully that'll become clearer and clearer. We're going to be talking a lot about drug targets, so hopefully we'll get used to talking about the receptors. It depends. But just keep that in mind for now. You are going to see some different stuff going on. All right. Those are the quick highlights in terms of what you need to know for therapeutics. They're important slides, so ask me now if you see anything on it that's making it easy. Nothing on either one? Yep. What happens is you break these down into metabolites, right? You don't need to worry. There's going to be a slide I'm going to show you in a couple where you look at probes. We'll get there in a minute. Where you're looking at breakdown products. You don't really need to worry about that. With the exception of these three slides I have coming up, we're actually going to be the one that I want to work on. All right?
So the autoreceptors are like negative feedback. So if it senses there's like a high concentration of norepinephrine in the synapse, it will stop the presynaptic neuron from releasing norepinephrine?
Right.
Okay.
Right. Exactly. Now, keep that question in mind, too, when we start talking about receptor sensitivity changes. Okay. Now, etiology of depression goes way back, and it's one of the classic examples of reverse engineering. We knew what a drug did. We knew that a drug would manipulate norepinephrine, for example. And then we saw outcomes that looked like depression or vice versa. So one of the earliest examples is Zerpine, which was being explored as a way to deplete norepinephrine, because norepinephrine runs by your sympathetic nervous system. And Zerpine was being looked at as a way to treat hypertension, depleting norepinephrine. And what they found is that a large chunk of the clinical population in the study was becoming depressed. So that's a classic example of reverse engineering, where you know how you know what the medication does, from a rat model, from all the basic science domain. You think that it blocks or that fits into the med-chem and all these things, but you don't really know what it does to humans. You think what that norepinephrine drug is going to do is you think it's going to treat hypertension, and maybe it does, but what you find out is in humans, what it actually does is deplete norepinephrine stores to the point where you're depressed. Reverse engineering. And we can now say that for serotonin, norepinephrine. And if you deplete these, the classic example I was alluding to in substance use, you go out and go on a drug binge, and you deplete all your dopamine because your body, you're blocking the uptake from cocaine, and your body's using all the dopamine because you can't get it back into the synapses where you use it. And it's not like you're out eating a amino acid rich diet when you're on a cocaine binge, right? So you're not eating the precursors, and you're not recycling it. So what ends up happening is you use it and deplete it, but what happens in the cocaine withdrawal? They're depressed, and you're dying, right? So we now know that for all three. So every single, I think this is still safe to say, we're starting to the point where there's some novel medications coming out, but I think it's still fair to say that every medication that we talk about will somehow, in some way, act by increasing the activity of one of these three neurotransmitters. Eventually, that's not going to be safe to say, but it still is. How you get there is very good. How do you say that? Reserving. Reserving, yeah. Reserpine. Dysregulation. Now remember, I'm a big homeostasis believer, but I don't believe that it's one deficiency of one transmitter per se, but that's some kind of you're taking the body off homeostasis, right? I think that's pretty commonly held now. That you're not just because you're lower in serotonin, that's the end all be all, but it's you're low in serotonin, so you're not modulating this, or why are you low in serotonin because of this? There's some kind of system of balance that's probably more important. But we're going to talk a little bit about it. Now, receptor sensitivity changes that we talked about, where if you have, say in your question, right, you have a synapse that's flooded with you said norepinephrine, right? And so I come in, and I give you an antidepressant that blocks the norepinephrine channel, and you now flood. And I'm getting a little bit ahead of the mechanisms, because you're going to have to be able to tie this in to be successful in this section. You're telling me that presynaptic receptor is what shuts the firing off, right? Right. And
Yeah.
that was correct. That was correct. What do you think happens to that receptor with long-term activation?
They become less sensitive to chemical.
Right. So what happens to the cell firing?
It's downregulated.
Well, remember, when you activate the receptor, you're slowing down the neuron. But then you just said correctly that you're decreasing the sensitivity of the brake. So what happens to cell firing? It increases. You've taken off the brakes because you desensitized the brakes. One of the prevailing theories in a lot of these medications is it's not just the fact that you're going to desensitize postsynaptic receptors, but the fact that you're going to desensitize presynaptic receptors, take off the brakes, and allow the system to fire more efficiently. Now we're going to revisit that. I just wanted to tie it in there since you asked that question, because you're going to have to see the difference. You're going to have to know the difference between post and pre. Very important. And that's why I say clinically relevant time course. This is one of the cool things that, it's like a study. It's like a study I wish I had done. When I read some of the studies on time course receptors, it's something I wish I would have done, been able to say, oh, that was me. Because what they were able to do is show the timeline from when people got better corresponds exactly or very closely to when these receptors downregulate. So there's a very strong correlation between, oh, look, you took the brakes off your neurons after a couple weeks, and that's also when you got better. It also explains why initially, when you think before I give you the antidepressant, do you think your receptors are up or down regulated? Before I give you the antidepressant, based on the first period. Down? Who said down? Anybody say they're up regulated? Why?
Because you have a reduced amount of the norepinephrine, serotonin, and or dopamine. So not as much signaling is happening, so the receptors aren't being desensitized.
So if I heard you correctly, you don't have as much neurotransmitter, so there's not as much activity because you have a deficiency in neurotransmitter, so your body does what to the receptors to compensate?
Probably puts more out.
Puts more receptors out because it's looking to transmit, right? Your body's looking for that homeostasis. By upregulating the receptors, you're trying to restore the balance that's being caused by the deficit of circulating neurotransmitter. So now when I first give you a drug, a medication, you have upregulated receptors and you have more transmitter floating around the synapse. So now you have too much activity in the system, and that's where a lot of people get side effects. When we first start antidepressants, they're anxious, there's sexual side effects, GI side effects, insomnia. But a lot of that stuff goes away over time, and people get better. And a lot of that's attributed to some of these receptor changes that occur, more than just, oh, we're increasing the absolute level of serotonin and norepinephrine or dopamine. I hope that was clear. So the next three slides are nearly identical in what they say, all three of these slides. It's kind of that reverse, it's more of that reverse engineering, modality that we know that all antidepressant efficacy is based in some way, shape, or form on increasing norepinephrine, dopamine, or serotonin. We don't exactly know if that is then you're waiting for something downstream, or you're just fixing something that's downstream from something else. And a lot of that stuff's still being used apart. Inflammatory markers, what's needed after the question, or the least common denominator, all right? The least common denominator is that all antidepressants in somehow or some way increase the activity of these neurotransmitter systems. All right? And again, same slide, 3 different times. There are a couple subtleties. We use probes. I'm not going to get too much into probes, but it's basically saying, you use a pharmacological probe. In this case, for serotonin, you would use a serotonin probe to get body temperature. Then you give a medication. You give another serotonin agonist, and you measure body temperature again. And the blunt of that you know that you've done something with your probe, right? Well, there are a bunch of studies to suggest that a depressed population will respond differently to these probes than a non-depressed population, and so on and so forth. So I'm not going to get it wasn't that successful of a concept last year in therapeutics, so I'm not going to hone in on it too much, but at least it has to be mentioned. If you wanted to go dissect depression, you're going to run into probing and using agonists and all that. So I kind of threw it in there just for your own edification, but I'm not going to really center on it. All right? Just remember, reverse engineering. That's kind of the thing I want to do. All right. So now we're going to talk a little bit about the neuroanatomy of depression, some of these brain waves. So this would be, when we talked about substance use behaviors, we are talking a lot about the reward system that goes from the ventral tegmental area to the stomach. We're going to talk some about some brain areas that are analogous to the reward system. For example, using that same brain area, there is thought that if you remember me saying there's a reward deficiency theory of addiction? Do you recall me saying that? Where one theory of addiction is that people who are more prone for using substances probably have an underactive reward system, so they're seeking it out and taking large quantities of substances. Well, there's the analogous theories for that if your reward system is not operating at full capacity, that you be more prone to depressive symptoms. Right? Makes sense, right? You're not experiencing reward, the motivation is down, the drive is down. It looks like depression. So there's theories that in some areas of the brain it may actually be underactive. The brain is underactive in that area. The flip side of that, and it doesn't have to be mutually exclusive. These do not have to be mutually exclusive findings. The flip side of that is that some areas of the brain are overactive. Now, does anybody remember what I said the amygdala does at a broad conceptual level? Hold on, raise a hand so I can pick somebody into one that is right. Who's going to raise my hand? Okay. Emotional memory. So it's one of these centers that, there's that emotional piece tied to your memory, right? It's not just a pure memory. If you're remembering a number that elicits no particular, emotion, that's probably more like the hippocampus, cerebral cortex. But if you're remembering an event, like nostalgia, right? Everyone's got nostalgia. You drive by your own house, and there's the memory of that house, but there's the emotional component, right? Or something that scares you, like a spider. Are you arachnophobia? Right? So you have an emotional, if you thought about the spider before Jorge swooped in and saved you, would it cause your body a little bit of a response? Right? How about the spider, not Jorge? Gotta have some fun. That would mean that your amygdala's over that, right? Your brain's putting too much importance on the spider. Right? The spider's probably not going to hurt you. There are no poisonous spiders in the game, right? So maybe the amygdala's overactive. So I want you to start thinking about her overactive amygdala when you start talking about depression. Not her, but the generic, nameless amygdala. So what you want to do is you want to look at the symptoms of depression and think about the areas that we talked about in the past that may be impacted. Okay? If you think about, I already covered interest, the motivation, the reward, the nucleus accumbens. If that area, the reward center of the brain is underactive, okay, it looks like anhedonia. If I look at the hippocampus being underactive, it looks like memory issues, neurocognitive. These are all symptoms of depression that you can kind of map onto the brain. Basal ganglia, striatum. Who's seen a depressed person who just sits around all day, doesn't go anywhere? Who's seen somebody who's clinically depressed doesn't move for days? I'm surprised it's that few. I would be willing to bet it's more than that, so you aren't raising your hand. They're amotivated, which would be more of the nucleus accumbens, but they're also their drive to actually move. They're just not moving. Their basal ganglion striatum, that whole area in the frontal area of the brain that drives motor movement is under function, right? So you want to think about brain area and how that maps on to what you see in depression. And then ultimately, what we're going to do with the antidepressants to reverse that. So I'm going to get to the clinical presentation and the depression, but there are a lot of different symptoms, right? This person's anhedonic, this person has cognitive dysfunction, when I get to the symptoms, I'll come back to your question when I'm having that done. Right now, I'm just trying to, you have to be successful in this section. You have to think about brain area, what the symptom looks like, and what we're going to do antidepressant to address that symptom, that underlying disorder. When I come back to DSM-4 to 9, right? But for the 30-second version is memory impairment. There's a lot of memory impairment in depression. That would lead to campus, decreased interest in the board. That would lead to succumbins. And somebody who has what's called psychomotor retardation, where they're not moving, but just sitting there, that would be moving something in their brain, which is distracting. Again, I like pictures. We talked about these, the emotional memory, the memory. We take a look at that. Now, let's move on to the HPA axis, right? So this should be more review. HPA axis, the hypothalamic pituitary adrenal axis. Now, it's one of my, I find it very interesting, this whole HPA axis and for depression, chronic stress, and everything that we're about to talk about. Now, again, the chicken or the egg, is your HPA axis, which I'm going to argue in a minute, is disrupted in depression. Is that because of something, or is that causing something, right? Is your HPA axis abnormality because of something else, or is it causing something? You're causing this, and we're gonna piece that apart in a second. Just wanted to highlight a couple, hormonal systems you should be thinking about. HPA axis, I'm probably going to spend 5 or 10 minutes here in a minute. Thyroid axis, I'm not going to spend much time on, but again, it's another one of these kind of reverse engineer situations. If you look at the STAR-B trial, does anybody remember the STAR-B trial? Who remembers the STAR-B trial? A couple of them, right? What was it?
It's based on the theory that not every antidepressant or medication works the same on different people. So that one person might be good on an SRI, or another might be more. Yes, an article. Or the SRI might be more efficacious on another one.
So they set out, if they, STAR-B investigators believe not everyone's going to respond to the same medication, the same rates, and so on. So they went out to study all these different approaches. If you don't respond to this, would you respond to this? If you don't respond to this, would you respond to this? Should we augment? Should we switch? What should we do? And what I want you to remember about the thyroid axis dysregulation and depression is that thyroid augmentation actually is pretty effective at getting people to respond when added on to an antidepressant. So if you had a group of people, a sample of people that did not respond to an antidepressant, by adding thyroid to that antidepressant, you can squeeze more efficacy out. And the reason for that rationale in the first place goes back further to show that a lot of people have depression, thyroid, not everybody, but you can augment antidepressant. Now remember, thyroid is activating, right? Everyone remember thyroid? If somebody takes too much thyroid, they're going to be activated. So, cardinal signs of depression being anhedonia, amotivation, lethargy, these things maybe are kind of, is it a direct effect on depression, or are you just activating them? In any case, you do get more people out of the depressive syndrome, the depressive episode, by adding thyroid.
Do you actually have hypothyroidism in order to
No.
have thyroid medication?
No. Yeah, a lot of the probes they were trying to look at for depression in the first place, like looking, could you use hypothyroidism as a marker for depression and things like that. None of them have really been that successful, because I can find somebody who's hypothyroid who's depressed, I can find somebody normal thyroid who's depressed, and so on and so forth. So that's why that kind of, nobody uses that as a screening instrument for depression. However, it doesn't stop you from augmenting with a thyroid agent. Because again, is it actually acting on the depression core etiology? Is it just activating them? What is it doing? It's doing something. That's about what we know at this point. It's doing something. And some of it's intuitive. If I cause you to be more activated and you're depressed, and I'm At the same time, relieving your depression and activating you, that makes sense. What happens if I activated you and I didn't relieve your depression? Hyper? A good hyper? Well, you could be, you're close, but I wouldn't throw out bipolar yet, but there is something I'm looking for. You're on the right track. Well,
Would you try and commit suicide, or are you trying?
that's when a lot of people do commit suicide, is when they get better from an antidepressant because they're more activated and they can actually, they've got a little bit of energy. However, right, their mood isn't completely resolved. So yeah, it's a dangerous game to increase someone's activity but not increase their mood. So what I'm saying is some activation in the context of improving someone's mood together. But you're along the right lines. Someone becomes irritable or manic. But I don't want to use the bipolar terminology yet, because once it becomes bipolar, then it's something different. It's no longer unipolar depression. All right. So HPA access, I'll review, right? Actually, I'll look right through this slide, right? Okay, good. So one of the theories of depression is that you have an inability, for whatever reason, again, chicken or the egg, you have an inability to slow down your HPA axis. That if you look at depressed patients, they have a high likelihood of having an elevated HPA axis, elevated cortisol, for example. Now, it gets a little more complicated because what about the elevated HPA axis is causing the problem? What is it? There are a couple of theories. A couple of them that have some pretty good evidence. One of them is, you know for a fact that if you walk around on a daily basis with cortisol flying through your bloodstream, that you're probably shooting from hippocampus. Right? This has been known for a long time. But if you activate the HPA axis on a chronic basis, you are going to have hippocampal shrinkage. Alright? Not a good thing, right? That's your memory centers. That explains part of the problem. That, okay, you can't remember as much. But that doesn't necessarily mean that if you're decreasing the hippocampal volume, what are you doing to other areas of the brain that maybe aren't as obvious, or maybe you just haven't discovered it. The point being, there seems to be something toxic. It seems to be a toxic situation to have cortisol flying around all the time. Now, you ever watch TV at night, you see all the adipose tissue commercials, and they all claim you can block cortisol, you'll block, getting the gut, right? And maybe there's some truth to that. But I'm not going there. I'm going that same analogy, too much cortisol is toxic to the brain. And I'm going to show you some more evidence here in a minute. So, last year, did you guys ever get tired of hearing me talk about being at school? I know Jonathan didn't. So one of the leading theories, I hate to say the leading theory because things change and all that. I hate to use absolutes, but a very interesting theory, I'll leave it at that, is that one of the ways in which depression may manifest is by elevated HPA axis, leading to elevated cortisol and such, which ultimately increases brain-derived neurotropic factor. Does anybody know, before I go on, what brain-derived neurotropic factor is? Not one person? Okay. So I'm teaching you guys something today. It's a member of the neurotrophic family that regulates the differentiation and survival of neurons. Alright? So, I'm pretty sure in my lifetime, professional lifetime, I can remember when we still thought that the brain didn't grow. Right? Past or not. it used to be kind of depressing, you're 22, once you're past 22 or 25, that your neurons no longer grow. Does anybody remember that? Right? Some of you remember that, right? Well, that's no longer what we accept. Now what you accept is, you may not be growing more neurons per se, but you're growing more synapses. You now know unequivocally, without a doubt, that you grow more synapses. Perfect example that I can think of is somebody who has a stroke, right? Rehabilitation, part of the rehabilitation that goes along with the stroke is rebuilding connections amongst neurons that allows them to regain function, right? Some of that regrowth and regeneration is going to be, if you traced it back, you would find BDNF and other neurotrophins, okay? Brain-derived neurotrophic factor, the one that we're going to focus on for this course, is the only one I really want you to, but there's like, what, glial derived neurotrophic factor, there's a bunch of we're talking about one, right? So not that cruel. It's only one neurotropic factor that we're going to talk about. BDNF. But going back to the stroke example, BDNF is probably involved in those neurons growing and talking and communicating and allowing that person to have some function back. Or some other neurotropic. So, this is a pretty cool slide. This is another one of these studies that you wish you did. I'm not a basic scientist, but if I was, this would be a pretty cool study to be part of. Where if you look along the top, what you have is all the way to the left, you have a neuron with an normal state, right? In the normal state, and you look at the dendrites coming off this neuron that are gathering information. I remember the dendrites that are gathering information. You look in the middle, now that is the case where you have excess HPA axis. So the middle is where you're in the toxic state, and you have glucocorticoids circulating through the system and damaging neurons. And the reason that it's thought to damage the neurons is by decreasing BDNF. To the right, and this is my favorite column of the three, after antidepressants, lithium, ECT, we're not going to talk about TMS in here, and exercise. My favorite one being exercise. I was joking last year. I do a lot of trail running, and I was joking with the class that, I think about my BDNF growing when I'm trail running. You have to, trail running, you have to adapt, and you're looking for obstacles. And that whole time, my brain has to crank up BDNF to adapt to the different, trails that I'm on. So, what I'm saying is I believe in this theory, so you're probably likely going to see BDNF again at some point on an assessment. Without sounding like too much of a dork when I run. But I am. I have actually thought about doing that when I run. But these things actually reverse it. All right? That's the take home for therapeutics, is that you can actually reverse the changes in BDNF. So if you have, a state where someone's depressed, right? Or you induce a state of depression in the rat model or so on and so forth, and you decrease BDNF, you have less dendrites, you can reverse that process with antidepressants, ECT, exercise, and you actually grow more dendrites, and you have more BDNF, which is also what the next slide says. This was in patients that would get serum BDNF before and after treatment with an antidepressant. So, again, these are all tools. Whether or not this ends up being the ultimate theory of depression or not, or we find that it's some other related mechanism, what we know is this is not 30 years ago, probably not even that long, when somebody said it was all in your head. You now know that depression, like diabetes, there's some kind of problem at the functional level. Now, teaching a class in 2012, that's not a huge ring to go out on. Whereas probably as early as 20 years ago, if I were to say that, people would be like, what are you talking about, right? It's nothing like diabetes. Diabetes, we can look at the pancreas. But we can now look at the brain through imaging, through BDNF, through looking at dendrites, immunohistochemistry to count the dendrites, it goes on and on and on and on, to show that not only are there deficits in brain function, but that you can reverse those with medication.
What could make someone who wasn't depressed take an antidepressant and become like really happy or manic if that theory is true?
Because it's a great question. The thought is, again, you have to remember homeostasis, right? You're thinking along the more is better philosophy, and people don't believe that's the way the brain works. That just more neurons firing, more synapses is necessarily a good thing. If you're already operating well, and you just start cranking up the number of dendrites and keeping synapses, there's also thought that could be problematic. An easy thing to think of would be something like anemia, where you've induced a state of hyper-arousal, hyper-awareness, but those people can function properly. Or maybe you can't, they can't think clearly, right? Have you seen they cannot think clearly, but you could argue based on just the energy and the alertness and the fact that they're an antidepressant, that they're more active and they have energy, but they're not functional. So you have to remember there's the balance. That's why I always go back to the balance. If you're already normal, just taking more of a good thing is not necessarily a good thing. But there is. I used to have a slide, I think it's in the pathophysiology version of this part of the lecture, where I talk about that there may be some elevated gene abnormalities and stuff like that. So it is possible. Clinical presentation. So, again, GSC4 criteria. Now, I told you I would go back to thinking about how symptoms would map onto brain regions. If you look at some of these, and they're not all going to map on perfectly, but if you look at some of them, you can start to tease them apart. Depressed mood, I told you, could either be a place like the nucleus accumbens, it could be part of the prefrontal cortex, where you process information, you process reward, you process motivation. Sleep, if you have an activated amygdala, for example, and we're going to talk about that with anxiety as well, if your fear response, and just to keep picking on you for a second, I know you're like, if her amygdala is so overactivated that she's thinking about the spider tonight and can't sleep, right? And that happens to some people, right? I mean, it's possible. But an overactive amygdala, the overactive fear response, might drive her to have insomnia. Now, none of this happens in isolation, which is where it gets very complex, and a lot of these symptoms are overlapping. It gets hard. But you need to be able to think about how the area of the brain would map on these symptoms and generalizations. Because you can make it very complex. I watched the guy give a whole presentation on increasing dopamine in the nucleus accumbens and how he helped with the mood of depression. But then I had a question kind of like yours, Rachel. Well, that's only one area of the brain. What happens if I increase dopamine in the nigrostriatal, tuberoinfundibular, or the mesolimbic? Right? He was saying that if you increase the mesolimbic, I was saying, what about the mesocortical, or vice versa? Because if you increase, you're going to talk about 4 pathways in schizophrenia, the 4 that I just mentioned. Have anybody heard of those yet? Mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular. You're going to talk about those at length. And I don't want to go there right now. I don't want to steal Devin Sherwood's, her lecture. But basically, I have the same question. If I increase dopamine in this area of the brain, you're saying that's a good thing. What about this area? And his model didn't account for that. And you can't tie in everything together. But for the purpose, at this point in time, but for the purposes of this course, you need to be able to try to, think of these things as if they were in isolation. Right? Otherwise, we'd all be very confused. So you need 5 of 9, and they need to be present for at least 2 weeks, and either symptom A or B must be there, meaning a depressed mood or lack of interest in activity. One of those 2 symptoms has to be there for a diagnosis, and they have to be present for at least 2 weeks. Everybody's had a depressed mood for a couple of Everybody. Everybody's felt new or low at some point. It's part of the normal fluctuations of different existing, right? Everybody. However, if it starts persisting for 2 weeks, that's a big chunk of time. And 5 of 9 of these symptoms are present. And, I'm going to come back to this slide, and you can't function, and it's causing you distress. Now you're talking about differential diagnosis. If you're just blue for a couple of days, but you shake it off after 4 days, or you walk around with a little bit of distraction, you're a little bit tired, and yeah, your mood's not as great as it is, but then when asked, well, is it really impairing your function at pharmacy school? No, I'm still doing pretty good at pharmacy school. Is it causing you a lot of distress? Not really. I mean, yeah, I'd like more energy. I would like to be able to think more clearly. Yeah, but that's not a diagnosis. Right? Past the clause for significant stress, significant impairment can be there for a couple of weeks. And it can't be caused by a substance. It can't be for reasons. It can't be an organic brain product.
Okay, no, never mind. I was just going to ask you, how does grief tie into this?
That's the question I usually get. That's like one of the number one questions on this lecture is, now think about like how I try to explain bereavement. The answer is, some people do go on to become depressed, right? And at some point, you have to make the judgment call as to when it became bereavement and now when it's like, where it's become pathological. That's never going to be easy for anybody to do. But I've definitely seen people who started out, bereaved and months later, and everything we talk about still has to be that person and ruminating about it and function. At some point, you got to make the judgment call. There's no hard and fast rule. If you came in and said somebody, passed away 4 months ago, and I still haven't gotten over it every day, I think you can make a logical argument that's still bereavement. You have no history before that. If you come in and say someone passed away 8 months ago and I have 3 prior episodes dating way back, that's a different story, right? So you have to take in all the information and try to tease it apart.
Is there any literature affecting the brain change during bereavement or nothing like that?
Well, I don't know about bereavement specifically, but there are a lot of situations that we talk about where you can see acute brain changes. But it's the lasting brain changes that cause the impairment and the stress. Your brain is amazing at that's why I was making the trail running analogy. Like if I wanted a different trail, my brain has to adapt to that, and it remembers that. Things happen quickly, your brain adapts quickly, and you can see changes quickly. It's when they become enduring and they don't go back. Same with like the substance use. If I go out and go to a wedding and I have a few drinks, yeah, there's some changes. But if I do that every other day for the next year, it's going to be different. Same kind of situation. Suicidality. We're going to take the prison here today. That lady stole all my time. So I guess we'll have to do that tomorrow. Anybody read the article again? Well, there's going to be a question or two or something in the exam anyway. So you have a conceptualization of the article. It shouldn't matter if the quiz is today or tomorrow or last week. I don't ask questions of the details of what you have to memorize. You understood what we talked about. It shouldn't make sense. That's why I don't feel too bad about it.
2 slides previous to this, there's something at the bottom of the cap.
Good question. Sleep, insomnia, guilt, energy, concentration, appetite, psychomotor, suicidality. It's in the mind. Sleep, interest, guilt, energy, concentration, appetite, psychomotor, suicidality. Oh, it's sleep interest. Sorry. Sleep interest. You should be able to tease these apart by the criteria. The only one that's not in there is depressed mood.
Psychomotor
Right?
It's up there.
and suicide.
So, suicidality, this is a huge, huge topic, treating depression. And what we're finally figuring out is, yes, there does seem to be some signal for increased suicidality when you first start to address discussion in young people. But the absolute numbers are still pretty small. So the best that we can do at this point in time, the recommendations are to be very, very diligent at the beginning of treatment and monitor very aggressively at the beginning of treatment, especially in young folks. Because the signal's there, but the absolute numbers aren't staggering. So you have one person saying, well, the signal is there, and then there's another person saying, well, if you're talking about a very low absolute number of risk of suicidality and compromises, well, just be diligent up front, especially for young. Rating scales, we talked about these in the articles. This is all, we think about exaggerating the sustained stress response. That goes back to the EK axis and the talking and doing that. And I'm done. Any questions before we put 1 minute? Yep.
I know you're looking stuff with the battery that much added going into the effects of the antidepressants.
Yep.
But would it be by case, is there a guideline for it, or is it just the lowest dose battery?
That specifically or augmenting in general?
Augmenting that.
Great question. So, psychiatry is plagued with, I think plagued is the same word, with the lack of treatment recommendations where you can just go through and you say this works, this doesn't. The good news is it doesn't get boring. I would go crazy if I could just pull out a JNC 7 guidelines and everything was very cookie cutter. That could get boring. On the flip side, I wish I had something like that, where I could make, hey, this is what everybody agrees on. So it's very plus and minus. You are not going to find. You're going to find that I have all these. I've posted them in years past. I don't know how many people actually access them. Like the APA guidelines. There's like 3 or 4 guidelines that algorithm project. So you can get guidelines and recommendations on this. There is no gold standard system to do. But I can post those. Like I said, I have in the past, and I just don't know how they're overwhelmingly ignored or
Not necessarily, it's not very fair because it's not actually on this lecture,